Hello, my name is Jonathan Strasberg. I'm Section Chief of the Neuroendocrine Tumor Program at the Moffitt Cancer Center in Tampa, Florida. It's my pleasure to welcome you to this discussion exploring perspectives on the current status and recent advances in gastroenteropancreatic neuroendocrine tumors with insights into latest data presented at ESMO 2021. I'm here with Dr. Jennifer Chan, who's Clinical Director of the GI Center and Director of the Program in Neuroendocrine Tumors at Dana-Farber in Boston, as well as Dr. Marianne Pavel, who's Chair of Endocrinology and Head of the NET Center at the University of Erlangen in Germany. So today we're going to look at current approaches to therapy of gastroenteropancreatic NETs and the role of innovations in expanding our treatment options and practice recommendations, and particularly focus on latest data presented at the ESMO 2021 Congress. So let's start with a little background. Where are we right now? And so we're going to talk about current treatment options for patients with well-differentiated gastroenteropancreatic neuroendocrine tumors. Later, we'll focus a little bit on poorly differentiated tumors as well. So there's no doubt that the incidence of neuroendocrine tumors is rising, both in the United States, Europe, as well as Asia. To what extent it's related to true increase in numbers versus increase in recognition by pathologists, incidental diagnosis, as well as a result of patients undergoing more scans and endoscopies. It's hard to say, but the numbers have increased approximately fivefold in the past several decades. And as far as prevalence, actually, neuroendocrine tumors are the second most common GI neoplasm after colorectal cancer in terms of the number of patients actually living with disease. In terms of how this breaks down, there's quite a few rectal neuroendocrine tumors. Many of them are small and benign. The minority are metastatic. Small bowel neuroendocrine tumors tend to be slow-growing but malignant. Most of them are diagnosed in the metastatic setting. Pancreatic neuroendocrine tumors also often metastatic, but increasingly we're finding small incidental pancreatic NETs. Gastric neuroendocrine tumors are often small, incidentally discovered, often related to atrophic gastritis. And again, the numbers have increased quite dramatically in the last 3 or 4 decades. There's a lot of different prognostic factors for neuroendocrine tumors, including tumor stage, tumor grade and differentiation. High grade often correlates with poorly differentiated histology, although you can have well-differentiated high-grade tumors. Whether the tumors are confined, metastatic tumors are predominantly confined to the liver, or whether they're widely metastatic, whether they express somatostatin receptors. These are all prognostic factors and also impact treatment. As far as the current treatment paradigm, if patients have metastatic disease, we often start with somatostatin analogs, either octreotide or lanreotide, both for control of tumor growth as well as for symptom control. If tumors progress in the midgut, primaries, we often perform liver embolization if the tumors are predominantly in the liver, but otherwise the main treatment option is with peptide receptor radiotherapy using lutetium dotatate. Everolimus is sometimes used, although the efficacy in functional midgut NETs with carcinoid syndrome is relatively marginal. For pancreatic NETs, there's a lot of different treatment options, including everolimus, which is an mTOR inhibitor, sunitinib, which is a VEGF receptor inhibitor, chemotherapy, for example, with capecitabine temozolomide, PRRT also used in pancreatic NETs, and then for patients with liver-dominant tumors, you can also do liver embolization. And then for the less common colorectal, gastroduodenal, lung NETs that metastasize, everolimus is a standard option, PRRT if they express somatostatin receptor strongly, liver-directed therapy, and sometimes chemotherapy as well. And this is for well-differentiated tumors. For poorly differentiated neuroendocrine carcinomas, the standard first-line treatment is with platinum etoposide, which has been the case for many years. So let's go a little bit deeper in terms of pancreatic NETs versus GI NETs in terms of biology and treatment. And maybe, Jennifer, I can start with you and talk a little bit about how you think about them differently.
Thanks, John. I do think it's important to recognize the primary site of neuroendocrine tumors because the biology, as you mentioned, differs between GI-NETs and pancreatic NETs, particularly with respect to responsiveness to chemotherapy. For instance, we'll routinely use temozolomide and capecitabine for pancreatic neuroendocrine tumors, but less likely to use cytotoxic chemotherapy for midgut neuroendocrine tumors. I think where we also have seen some differences is with respect to standardly available tyrosine kinase inhibitors. We, for years, have had sunitinib as an option for treatment of pancreatic neuroendocrine tumors, but until recently, we've had much less data regarding the efficacy of tyrosine kinase inhibitors in extra pancreatic neuroendocrine tumors. That certainly has been changing over the last couple of years with the results of the randomized phase 2 trial that was presented at ASCO a couple of years ago, looking at pazopanib versus placebo for patients with extra pancreatic NETs. There also is phase 3 data now with surufatinib versus placebo in both pancreatic and extra pancreatic NETs. That was a positive trial. And then at this year's ESMO and also ASCO GI, we learned the results of the AXINET trial, which was a randomized phase 2/3 trial of axitinib versus placebo in combination with octreotide LAR in patients with extra pancreatic NET. I think what was interesting was to see the updated results for progression-free survival in the axitinib trial at ESMO. At ASCO GI, we had learned the results of PFS data based on investigator review in the trial, and it showed a non-significant improvement in progression-free survival based on investigator review. This year at ESMO, we did learn that the results of progression-free survival based on central blinded radiology review showed a positive result in favor of axitinib. So I think it certainly brings up questions regarding the role of investigator review and central review as we conduct the clinical trials, and where there may be some discordances in local and central review that may influence results. But I think as we look at all of these trials, both pazopanib and surufatinib and the axitinib data, we have seen kind of a consistent message that tyrosine kinase inhibitors have activity in extrapancreatic NETs. So I think we'll have to wait the decisions regarding the regulatory agencies about whether there's going to be approval of these agents.
Great. Perhaps we can talk about the results of the overall survival results of the NETTER-1 study, which were updated this year. So the NETTER-1 was a randomized phase 3 study of lutetium dotatate versus high-dose octreotide in patients with progressive midgut metastatic neuroendocrine tumors who had progressed on a somatostatin analog. The PFS was the primary endpoint and showed a very significant improvement, roughly 80% improvement in PFS with lutetium dotatate versus high-dose octreotide. This year, we presented the final overall survival data. Now, it's important to remember neuroendocrine tumor studies are not well-powered to evaluate overall survival, both because the numbers of patients on these trials is relatively small and the long-term survival durations is quite long. So you would need a very large study to conclusively demonstrate survival benefit. And indeed, what we saw with the NETTER-1 is that there was roughly a 12-month difference in median survival favoring lutetium dotatate versus high-dose octreotide, but it was not statistically significant, which is probably not a big surprise given both the lack of power as well as the relatively high crossover from patients who were on high-dose octreotide and eventually received PRRT, primarily with lutetium dotatate. It was approximately 36% who crossed over. And so this undoubtedly impacted statistical significance. Marianne, how do you interpret the overall survival results of NETTER-1?
Yeah, thank you, Jonathan. I think we have limited options in intestinal NET, and this study is clearly related to midgut NET that had been progressive on prior SSA therapy, and a minority also had received other treatments. And this is a treatment that showed prolongation of progression-free survival that was really remarkable. Median PFS had not been reached after 2 years, while it was 8.4 months with high-dose octreotide, the double dose of the standard dose, what is 60 milligrams per month as a comparator. And that gain in overall survival amounts to nearly 12 months. It was not statistically significant, but if you keep in mind that these patients have a median overall survival based on the SEER database of 8 years and already had received for a couple of years prior SSA treatment, I would guess that 1 year is meaningful. Putting that into perspective with other treatments that we have available, it's only everolimus, and Jennifer Chan just pointed out that TKI are upcoming. This is an emerging therapy, but currently not approved and available. And so we just have either high-dose SSA or everolimus as alternative options in advanced mid-gut-NET, while chemotherapy doesn't play a role except for very aggressive mid-gut-NET that are highly proliferating. So I think this treatment is very well settled as a second-line treatment based on the strong effects, the good quality of life, also treatment breaks. Patients receive 4 cycles of PRRT. They went on a maintenance therapy with SSA that is well tolerated, so that is associated with a good quality of life, and that study has shown also exclusively that quality of life is improved. So taking that together, the strong effect on the PFS and the quality of life improvement makes this a very attractive treatment for patients and has settled as a second line in the ESMO guidelines. And I would guess that this lack of statistical significance in the overall survival would not change that approach.
Moving on, we'll be talking about the role of innovation in GEP-NETs and development of novel therapies and approaches to potentially further optimize outcomes in patients. So in terms of peptide receptor radiotherapy, lutetium dotatate is the current standard of care approved by the FDA and the European medicines agencies, but there's been a lot of developments. One of these is lutetium dotatate, which is fairly similar, but also combinations designed to help us improve radiosensitivity with PRRT. One of these approaches is to add cytotoxic chemotherapy, such as CAP-10. The data suggests that outcomes may be a little bit better in terms of overall response and PFS, but there does seem to be an increase in long-term bone marrow toxicity, particularly myelodysplastic syndrome, acute leukemia, which at baseline is about 2 to 3%. That may increase a little bit when you add chemotherapy. There's other approaches such as adding PARP inhibitors, adding triapine, which is a radiation sensitizer. There's lutetium OPS-201, which is instead of using a somatostatin receptor agonist, you use a somatostatin receptor antagonist as the ligand. And then there's alpha emitters. There's lead dotamtate and actinium-225 dotatate, which are completely different type of radiation using alpha rather than beta emission. Jen, do you have anything to expand on what you consider to be the most promising approach as far as new approaches to PRRT?
I think, as you mentioned, there are a number of different approaches that have been investigated, but I think the data regarding the alpha emitters is actually quite interesting, quite promising. Potentially with these, shorter path lengths, there may be still efficacy but less toxicity. So I think this could be another option for our patients with the results of trials that will soon be ongoing.
Marianne, anything to add to this?
I think what is very interesting to combine, for example, PRRT with immunotherapy to turn immunologically cold microenvironment into a more sensitive microenvironment. And I think a study is ongoing in that respect that could be very promising, but we clearly need more data to really make a final conclusion what is the best combination option, but it should be one that is tolerable and less toxic than the combination with chemotherapy and PRRT.
As Jennifer mentioned before, there are many new tyrosine kinase inhibitors that are being evaluated. Perhaps the most advanced as far as approval is surufatinib, which was actually studied in 2 Chinese phase 3 studies in pancreatic NETs and in non-pancreatic NETs. I think it's important to emphasize the TKIs probably you get to see the most benefit in patients whose tumors are progressing relatively aggressively. So relatively aggressive pancreatic NETs relatively aggressive non-pancreatic NETs. And there's obviously been lots of studies of immunotherapy in neuroendocrine tumors, as there have been in just about every other cancer. To summarize the data so far, I would say that in well-differentiated neuroendocrine tumors, there's very little evidence of activity, either of single-agent PD-1, PD-L1 inhibitors or a combination with CTLA-4. An exception may be tumors that have been heavily pretreated. Sometimes we see responses in, say, pancreatic NETs who have had multiple different lines of treatments and may accumulate mutations as a result. But in poorly differentiated carcinomas, there is some indication of activity. Let's talk a little bit about the ESMO study, NIPI-NEC, which evaluated ipilimumab and nivolumab in gastrointestinal and pancreatic neuroendocrine carcinomas, as well as poorly differentiated lung neuroendocrine carcinomas, large and small cell. How did you interpret that data? Jen, maybe we can start with you.
Sure. I like to think about this data in the context of what we've already seen from some of the other data that has looked at dual checkpoint inhibition. I think what's interesting to see in these results is that the response rates to Ipi-Nivo, and certainly Nivo alone, were not particularly high. With Ipi-Nivo, as you mentioned, some of the earlier studies had suggested a very high response rate of 30 to 40%, but I think we're seeing that less now. I think what we also don't entirely know is who is responding, what the molecular predictors of response are. I think there are some patients, even though the response rates overall may be low, who may have longer term survival benefits, who have survivals that are 1 year or more. So I think that's probably the main point I would draw from all of this data, whether it be this NIPI-NEC study and the DART trial and even the DUNE trial, is that there are some patients who have kind of longer term benefit, even though the response rate might not be particularly high in general.
Right. Yeah, I think we're starting to zero in on the true response rate to dual or doublet immunotherapy, particularly with Ipi-Nivo. And there's now been several studies suggesting that it's in the low teens. In this particular study, it was a little bit lower in the gastroenteropancreatic NET cohort than the lung cohort. And the lung cohort is about 18%. In the gastroenteropancreatic cohort, it was about 12%. We saw virtually the identical response rate when we looked at our own experience with Ipi-Nivo. And clearly patients, that are MSI high or very high TMB will have higher response rates. But we've seen some patients, very rare, but some patients with relatively low mutational burden who have had long-term remissions. And that's probably the key. I mean, this treatment doesn't seem to have any impact on median overall survival or median PFS, but it's the tail of the curve, the 5 to 10% that have long-term partial remission, for example, or complete remission, where that's driving our use of these drugs. But Marion, what is your thought on where Ipi-Nivo stands in the second or beyond for poorly differentiated neuroendocrine carcinomas?
Yeah, it has been well summarized that these data contrast a little bit to the earlier data where higher objective response rates were reported. I think it's good to have another study that looks into the combination versus monotherapy. I doubt a little bit if the objective response rate is the best outcome parameter. We had the same required for spadalizumab study as a monotherapy, and objective response rate of 10% was achieved here, and it's higher for the combination. However, it did not translate in differences in overall survival, and I think overall survival is really a key endpoint in the NEC that have such a worse prognosis. 20% survive 2 years. And the disease control rate was also not different between mono and combination therapy. As you just said it, we need to better understand the subsets that are really susceptible to immunotherapy and better understand subgroups who might be candidates for that treatment. For me, it's not the conclusion that the combination is really better with respect to overall survival or the outcome of the patient. We also have to put this into perspective with chemotherapy. The second-line chemotherapy that we are currently using is either FOLFIRI or FOLFOX. And this comes from small retrospective data that can, of course, not be compared with a prospective study, but there it was reported around 30% objective response rate and median PFS of 4 to 6 months. That is not different PFS to the immunotherapy. Immunotherapy is well tolerated, better tolerated than chemotherapy. And patients may be in a worse condition if they have undergone already cisplatinum etoposide, that it's maybe more favorable to offer them immunotherapy instead of a second or third line chemotherapy that is also not so powerful. But this is what we need to put into perspective. I mean, to better understand from tissue analysis who are good candidates. It seems not to be the PDL expression, as you just said it, but maybe we have too little data because patients with MSI high, that's less than 10% of the neck. Patients with PDL positivity, that's only 25% of our neck patients. Maybe we need to understand that at another level and to perform a study that is a comparative one, comparing chemo to immunotherapy in the second line.
Yeah.
And
but I wonder, I wonder if median overall survival, for example, or median PFS is a appropriate endpoint for immunotherapy. If you ask me if I had a progressive, poorly differentiated carcinoma and I have a 5% chance of meaningful remission, long-term remission with immunotherapy, or a 30% chance of marginal benefit with chemotherapy, I would probably choose immunotherapy, even if you might impact median overall survival a little bit more with chemo.
Yeah, I agree. Median overall survival is not good because we miss the good responders there. I think the disease control rate at 6 months would be maybe an endpoint to look at, 6 and 12 months, and to understand these subsets of patients who might have a benefit of immunotherapy.
And what about first line, adding a PD-1 or PD-L1 inhibitor to platinum etoposide? We know that in small cell lung cancer that results in a modest improvement in overall survival. We have single-arm data, the NICE-NECT study presented at ESMO in gastrointestinal pancreatic tumors. How do you interpret that data?
I think it is nice to see the data from the phase 2 trial, if it's only to give us a sense of the signal in response and tolerability. I do think that it'll be important to move this forward to a randomized study, because I think what we're trying to understand is the contribution of the immunotherapy on top of chemotherapy. The response rates to chemotherapy in the first line setting to platinum etoposide are also quite high, and I think we're just trying to see what we add with the immunotherapy, both for response and then ultimately survival.
Yeah, we've known now for a long time that you can add a PD-1 or PD-L1 inhibitor to chemotherapy, without significant increase in toxicity. But it's important to remember that small cell lung cancer is not exactly the same as poorly differentiated GEP-NET, even small cell GEP-NET. Small cell lung cancer is associated with smoking very strongly. There's almost certainly a higher mutational burden. So I'm not sure we can extrapolate small cell lung cancer data, even though many oncologists, I think, already are adding drugs like avelumab to chemotherapy in the first line. And just briefly mention FOLFIRINOX. This is retrospective data from Scandinavia looking at FOLFIRINOX for GEP-NETs, and clearly the regimen is active, even though it's quite toxic. Whether it should replace carboetoposide or cisplatin etoposide in the first line setting, I think, is debatable. Maybe in colorectal neck, where patients tend to do poorly with carboetoposide, FOLFIRINOX may be a little bit better. Let's talk a little bit about how to monitor patients. There are various guidelines. After resection, we know that patients can recur many years after potentially curative resection of local or local regional disease. So I think one of the key is to follow patients, not necessarily frequently, but for long periods of time. So Marianne, maybe you can tell us, how do you monitor patients after, say, resection of lymph node positive small bowel lower intermediate grade NET?
So a small bowel, I think they can be tiny, the primary tumors, and nevertheless metastatic. I think it's very important in the first year to stage these patients every 3 months. Unless they are G1 less than 2% Ki-67, then the staging interval can be prolonged to 6 months. Otherwise, in intermediate grade NET G2, we look for recurrence of metastasis every 3 months, and up from the second year every 6 months. And after 5 years, we prolong the staging interval to 1 year, because then the likelihood of getting metastatic disease is getting lower. I think that's very important to early discover recurrence, because patient can then undergo resection again. And we do that with conventional imaging. The predominant site of metastasis is the liver in mid-gut-NET. But overall, we also suggest to perform gallium dot PET-CT scan once initially to rule out distant metastatic disease, particularly to the bone and lymph nodes that are sometimes not detected on conventional imaging like CT, particularly if they are smaller than 1 centimeter in size. And then we perform repetitive PET-CT after 3 years, unless there is earlier detection by conventional imaging of any suspicious lesions where we think PET-CT should be performed earlier.
Well, I have to say, you're scanning patients a lot more than we do. After resection of a small bowel NET, we generally do get a baseline dotatate PET, either gallium-68 or copper-64. But as far as CT or MRI, we actually typically do it once in the first year and then annually for the first 5 years, then a little bit less frequently after that. This NCCN guidelines actually these days say every 1 to 2 years scanning. So there seems to be a little bit of a discrepancy between the US and ESMO data. And the way I interpret the data, at least for small bowel NETs, is that the risk of recurrence seems to be as much, 5 to 8 years after surgery as it is the first 5 years. It doesn't really change that much year to year. Jen, how do you monitor patients, for example, after resection of a lymph node positive small bowel NET?
I think, my approach is also similar to what you had outlined. I may, for instance, in the first year to two, scan, at the 6-month interval as opposed to just once a year. But I do begin to, once I pass 2 years, start to space things out. And certainly after 5, we have discussion about whether to continue annually or even to space things out to 1 to 2 years. I think what to do after 10 years, I think I trend to kind of individualize that recommendation. I don't know that I would follow everybody lifelong, but I think for patients who seem more high risk because of the extent of nodal involvement, I may extend beyond 10 years.
Right. And pancreatic NETs, we tend to monitor a little bit more closely after surgery, especially if they're grade 2 or relatively high grade 2. Those really tend to recur within the first couple of years. Although low grade sometimes behave similarly to small bowel. And then poorly differentiated neuroendocrine carcinomas obviously require closer surveillance. And then in the metastatic setting, we will monitor patients basically every 3 to 12 months, depending how aggressively they're behaving, if they have a well-differentiated neuroendocrine tumor. What about use of functional imaging for patients with metastatic disease? How often do you get that, Jen?
I don't routinely get functional imaging for follow-up. I think it's easier and probably better to follow patients with, either CT or MRI. I will get functional imaging if there is something that I'm concerned about, or if there's something equivocal on the CT scan. And I think there are some patients who have bone predominant disease where the functional imaging, I think, is preferable to CT or MRI. But while I may, as you mentioned, get CT or MRI on a every 3 to 6 months basis, I don't do that with functional imaging. It's probably just as needed.
Right. And what about tumor markers such as chromogranin? Marianne, do you check those routinely?
Yes, I check those routinely, but if we know that the sensitivity is around 70%, there are several assays around, but in general, it's around 70%. And if the patient has elevated chromogranin A and advanced disease, then we follow up. Of course, we need to exclude other reasons for chromogranin A elevation, like renal insufficiency, PPI intake, among others. There are at least 20 reasons that can cause CGA elevation, colic atrophic gastritis, and others. So we need to make sure that this chromogranin A elevation is really related to metastatic disease. And if it's informative, we follow up on that with the imaging in general. But if we also reach that point that we do the imaging only every year, then we also suggest to measure chromogranin A in between after 6 months without an imaging, and then along with the imaging after 1 year again.
Yeah. Yeah, we stopped doing chromogranin routinely simply because it tends to fluctuate. There's a lot of patients on PPIs, which invariably raise chromogranin, and often the labs change, and patients get quite anxious when the blood test changes, but of course the normal range can change as well. So we've stopped doing it on a routine basis, but occasionally it can be useful, especially if scans are difficult to interpret. As we discussed, anatomical imaging represents the mainstay of monitoring, and for neuroendocrine tumors, the CT scans really should be 3-phase in most cases to maximize sensitivity for detecting and measuring liver metastases. MRIs we often perform with EOVIS contrast. I don't know if you guys do that as well. But hepatobiliary phase tends to be quite good for measuring liver tumors. And then functional imaging, nowadays not so much of Triascan, but more gallium-68 or copper-64 dotatate or dotatalk PET scans. If we need to answer a particular question, or if tumors are hard to see on CT or MRI, for example, if it's mostly bone metastases, or in anticipation of peptide receptor radiotherapy. What about FDG PETs? Do you routinely get those, for example, for G3-NETs?
I haven't routinely gotten FDG PET. I think that it can, especially for the well-diff G3, it can provide some information to help you understand whether there's some discordance between somatostatin receptor PET and FDG PET to make sure that you're aware of all the disease that's there. But I will say I haven't routinely been getting FDG PET as part of the routine follow-up or staging.
I think it's important to do the FDG PET in patients where we consider adjuvant treatment after surgery, just to be sure that there is no residual disease, and that's a true adjuvant treatment in any NG3. Also, if we consider resection in patients with NEC that have isolated liver metastasis, we want to be sure that there is no other distant metastatic disease, so to exclude bone lesion if that patient is a good candidate for surgery. So I would definitely use it. Also in all patients where I consider liver transplantation, what is not very often, but then I just want to be sure with double PET-CT imaging, somatostatin receptor PET-CT and FDG PET, that there is no lesions outside of the liver. And as you said, Jennifer, we also do that in patients where we have suspicion of heterogeneous lesions. Sometimes it's a little bit difficult and challenging to really judge upon the somatostatin receptor expression. There's a Corning scale if you use the octoscan, but currently it's rarely used. Everyone uses gallium dotatalk PET-CT, so we have the SUV values. And sometimes it's important, particularly in foregut NET and in pancreatic NET, as well as atypical NET of the lung, to really make sure that all these lesions are strongly somatostatin receptor positive. So to really clearly draw the conclusion that these are good candidates for PRRT and to exclude mismatch, what you just mentioned, Jennifer. So I agree with you on that.
You definitely have to make sure when you're dealing with an aggressive NET, if you're considering PRRT, you have to make sure that all the tumors are lighting up strongly with somatostatin receptor scans. And that either means really carefully looking at the images on CT and MRI and correlating to the somatostatin receptor PET, or getting an FDG PET and matching those up. And it's certainly easier for a nuclear medicine doctor to match up an FDG PET and a somatostatin receptor PET to assure that all the lesions are somatostatin receptor positive. So this study evaluated how patients' experience and management compares United States versus Europe, or North America versus Europe. One thing they found is that delayed diagnosis is similar in both continents. And this has been discussed many times. Many patients especially with small bowel NETs, may have symptoms for many years before they're actually diagnosed. Things like chronic diarrhea or recurrent episodes of abdominal pain or bowel obstruction. So there's definitely room for improvement. These days, medical oncologists represent the majority of physicians focusing on GEP-NETs, but certainly not exclusively. There are gastroenterologists, surgeons, endocrinologists, perhaps more so in Europe than in North America. And multidisciplinary tumor boards are perhaps not utilized as often as they should be. This suggests that it's used in about 35%, a third of patients. But it's important to emphasize the management of neuroendocrine tumors is a multidisciplinary field that involves oncologists, surgeons, gastroenterologists, interventional radiologists, nuclear medicine physicians, endocrinologists. So there's definitely, we think, a benefit for multidisciplinary discussion and management. So I think this would be a good time to wrap up this discussion, and I want to thank you all for watching and exploring perspectives on the current status and recent advances in GEP-NETs. We hope it's been useful for you.